So delighted to introduce our next speaker, Katy Newton, who's going to talk about the impact of postoperative packing of perianal abscess cavities.
Yep. Hi,
Welcome.
Peter. Thank you. And thanks for the invitation to present our data again at this meeting. We published our paper a few years ago now, so I'm hoping to address, obviously, the trial results and then also look about possible de-implementation of this treatment. I'm a consultant surgeon now from Manchester. I was a surgical trainee for the whole of the 10 years it took us to design and deliver the trial. So I'm just going to go through a little bit of background of what perianal sepsis, what perianal abscesses are, and to help us understand the problem, I'll talk about our PPAC-1 study briefly. I'll then go through our PPAC-2 randomized controlled trial, talk about the methodology and the results. I'll then look as to whether there's any up-to-date evidence, and there's been 2 systematic reviews and meta-analyses published since we published our paper. I'm going to then ask some questions. Do we have enough evidence now to stop packing these wounds? Are we ready to de-implement? And if we are, how do we do that? So acute perianal sepsis, it's a painful abscess that develops around the bottom. Patients present with pain, sometimes systemic symptoms of sepsis. 90% of these abscesses are cryptoglandular in origin, so we think they develop because of a blockage within the anal glands, and the abscess then spreads up along the layers of the anal canal. According to HES data, this is a common condition. There's around 12,500 INDs, so incision and drainage operations each year. So in comparison, there's about 30,000 appendectomies, so fairly common. This affects a mostly young population. The average age is 40, and there's twice as many males as females. The current treatment, traditional treatment of these abscesses, obviously is an examination under anaesthetic, so general anaesthetic, incision and drainage of the abscess cavity, washing out the pus, washing out the abscess cavity, and then placing a single packing dressing in to start with for hemostasis. Patients are then discharged home to the care of community nursing with instructions usually to pack that wound. Abscess recurrence is an important complication of these wounds, and perianal fistula is a known part of the natural history also of these wounds. So to help us understand the problem, back in 2016 we published our first paper of the PPAC-1 study. This was basically an observational study and a feasibility study looking towards designing the main trial. We recruited 142 patients across 15 centres. This was mostly in the northwest. And we sent them home after having had the standard of care with some patient diaries just to gather some data as to what happened to them after their operation. We found that the mean age was 39, so as expected, a fairly young population, and on average they had 13 dressing changes over the first 3 weeks. We saw that the packing was painful, and they all reported a high visual analog scale score of pain scores. And we did some basic health economics, looking at how much packing costs, and looking at the cost of just the packing dressing alone. If we upscale that to today's money, this is £4 million a year that we're spending on packing in this setting, in this context alone. And we also found that the randomised trial would be feasible. So if we look to the main trial, so this is the impact of postoperative packing of perianal abscess cavities, a randomised controlled trial. The main hypothesis was basically that not packing these wounds would result in less pain, but we also needed to make sure that not packing was safe, so we wanted to look at equivalent fistula and abscess recurrence rates. Our primary outcome measure is a pain score, so we looked at the mean and maximum pain score on a 100mm visual analog scale over the first 10 days after the operation. We know that that's the most painful period from our prior study. And then in terms of secondary outcomes, we looked at perianal fistula rate, abscess recurrence, wound healing, health-related quality of life, and some other things, for example, return to work, which is clearly important, and global assessment and patient satisfaction. Everybody presenting with their first perianal abscess was eligible, or all adults over the age of 18. We excluded those who had a fistula evident at operation, those with inflammatory bowel disease, and those with Fournier's gangrene or a large horseshoe abscess. Patients then all had their incision and drainage operation and were packed at operation for hemostasis. Patients were then randomised post-operatively on a one-to-one basis to either receive packing or non-packing. This was a pragmatic trial. We didn't specify any further what the community nurses should do, just either to pack or to not pack the wound. Not packing generally involved patient self-care and external wound dressing only. Patients were sent home with a patient diary and asked to record their visual analogue pain scores a number of times each day, quality of life, whether they returned to work over the course of the first couple of weeks, and they were followed up for 6 months with both clinic reviews and telephone consultations. The trial went on for 2 years, and over that time period we recruited 433 patients across 50 NHS sites up and down the country. Just a very brief word about our consort diagram. We did a preliminary sort of interim analysis halfway through the trial and unfortunately found that we had quite a high dropout rate of people handing back their patient diaries. So looking in terms of the primary outcome measure of pain, we readjusted our number needed at that time to make sure that we had good statistical power. So looking at the 433 patients, their demographics, so the average age was 42 as expected, and there was an even mix of smokers, diabetics and men and women across both groups. If we look to our results, our primary outcome measure, so this is mean daily maximum wound-related pain over the first 10 post-operative days on a 100mm visual analogue scale. In the packing group, this was 38.2, and in the non-packing group, that was 28.2. So between the two groups, there was a difference of 10, which is a 26% difference. That's statistically significant. If we look at the published literature on how we should assess clinical meaningfulness of pain, a 10mm reduction is generally accepted as clinically significant, or 20%, and this is greater than that. You can see here on this graph, the red line being the packing group and the blue line being the non-packing group, that obviously, as you'd expect, pain is greatest in the first couple of days after the operation. Time is on the x-axis, pain is on the y, and as time goes on, both groups clearly improve with pain over the first 10 days. But there is a clear and sustained difference in pain between those two groups. We also looked at pain before dressing change, during dressing change and after, and as you'd expect, dressing change itself was most painful, but at those 3 separate time points, pain was more in the packing group compared to the non-packing group. If we just look at some of our secondary outcomes, so fistula and abscess recurrence rates are clearly important. In the packing group, we actually found there was a slightly higher 15% rate of fistula at 6 months, and in the non-packing group, that was 11%. And these rates are consistent with other published data on perianal fistula rate after abscess, incision and drainage. Abscess recurrence rate is low, 3% in the packing group and 6% in the non-packing group. Neither of these reached statistical significance to detect a difference, but if you look at our odds ratio of 0.69 in fistula and 1.85 for abscess recurrence in the wide confidence intervals, it's likely in there that there is a bit of a difference with a slightly higher fistula rate in the non-packing group, and in the packing group, and a slightly higher abscess recurrence rate in the non-packing group, but we weren't powered to detect that difference. And I'll talk a bit more about that later. If we look at healing, the non-packing group had a proportionally higher rate of healing at 6 months. It's difficult to know whether this is wound healing or whether this represents a slightly higher fistula rate in the packing group. Quality of life was similar on a fairly blunt tool that we used, the EQ5D, between the two groups. And if we look at return to work, interestingly, the non-packing group had returned to work more by 3 weeks than the non-packing group. So 3 weeks after the operation, 85% of patients in the non-packing group had returned to work, but only 65 in those packed. And whether that's to do with the number of trips required to a nurse for the packing, we're not able to say. So if we look at what we think we can glean from our results, so we can definitely say that packing is painful. We found a clinically significant reduction in pain with non-packing. We think we can say that perianal fistula rate is similar. There's possibly a true reduction with non-packing, and abscess recurrence rate is low overall, with possibly a small increase with non-packing. Healing at 26 weeks, so 6 months, is better in the non-packing group, and return to work is also better in the non-packing group. And we look back to our PPAC-1 data, we can see that packing is expensive. So the packing alone costs around £4 million across the whole UK each year. We think our data is robust, and this supports a change in practice to not use packing in the management of these perianal abscess cavities. We published our paper in the British Journal of Surgery 3 years ago now. So I wanted to see whether there was any up-to-date evidence, whether there had been any other trials or reviews. 2 systematic reviews and meta-analyses have been published since we published our paper. One in late last year by a Canadian group, and one fairly recent, actually just last month, by a group in London. Both these studies included the same 3 trials, so our randomized controlled trial, and then 2 smaller prior studies, both of which were randomized pilot studies only. One from an Australian group, which was published back in 2004, which included 43 participants only, and then a much smaller UK-based study published in 2015 with 14 participants. All these trials were relatively similar in terms of what they looked at, so they all looked at pain, healing, fistula and abscess recurrence rates as their important outcomes. The demographics between the 3 studies was similar. When we look at abscess recurrence, fistula formation, median pain scores, and healing, again, the findings are fairly consistent across the 3 studies, with all the caveats that the 2 smaller studies were randomized but were small pilot studies and non-powered. The more recent study performed a meta-analysis, and they were only able to perform that on abscess recurrence and fistula formation rate rather than the pain scores. Obviously, our study forms the most patients within this meta-analysis. There's 490 patients in total, 430 of which come from our study. And again, they raised the point that there may be a slight increase in abscess recurrence rate with non-packing and an increase in fistula rate with packing, with around 40 more abscess recurrence per 1,000 patients with non-packing, and 40 fewer fistulas with non-packing. So if we look to the conclusions of these 2 studies, so the earlier study from last year thought that PPAC-2 had a low risk of bias. The smaller studies, probably moderate risk of bias. And they were confident in their conclusions that packing is not associated with improved abscess recurrence or fistula rate, but does increase pain. And this study argues against the routine use of packing, but does suggest further studies to contextualise this use. The more recent systematic review isn't quite so bold in its findings, and suggests that we may need further adequately powered studies to investigate this further, but does accept that these may be hard to deliver. So what is our current practice? We published our paper now back in 2022. Are we still packing? So I'd like to ask you, the audience, some questions now. First of all, I'd like to ask you your role. I think you can use the QR code here to have a little look at the Slido questionnaires. I'd be very grateful. Are you a tissue viability nurse, a hospital-based nurse, a community-based nurse, a surgeon or non-clinical? Is it broken? Is it loading now? Thank you. I'll just give it a few moments and hopefully the results will appear. Have we got any results? So mostly TVNs, but a good smattering of hospital-based nurses and community nurses. And no surgeons, I'm the only one here. It's probably a good thing. So that's very interesting. Next question. We can move on to the next poll. Are you involved in the care of abscess wounds? Yes, excellent, 88%. Do you pack? Yes, occasionally. Yes, mostly. Yeah, no, never. Okay. So the minority all the time, some never, and there's an interesting mix of yes, mostly, yes, occasionally. And I'll be interested at the end as to how one decides on yes, occasionally. So if you pack, would you be interested to stop packing? Excellent. That's really good to know. Okay. So having conducted this study, I've presented at lots of surgical meetings, talked to lots of colorectal surgeons, and when I talk to trainees and other surgeons in my region in the Northwest and ask them, everyone is convinced that we shouldn't be packing. They say they write it on their discharge summaries, and they are completely convinced that the patients go home and are not packed. However, we do not deliver the packing. We rarely follow patients up in the clinic, so we really have no idea actually what's going on. There's a wounds group in Manchester, a wound strategy group, who have started to look into how we can possibly disseminate this information to the people that actually deliver the packing, and have done a small pilot study. This is unpublished data, so I'm just giving you a flavour. There's no exact figures here. The first part of the study, they conducted a preliminary questionnaire of current practice. They questioned about, I think, 60 to 70 nurses across Manchester, the majority of which were involved in packing in community or treatment rooms. And at that stage, around 90 to 95 were still packing. They then designed a really nice 6-month pilot study to try to get the education out there to implement de-implementation of packing. This project involved a bit of education, so the paper was sent out to initially just 3 community-based treatment centres. There was an education session done. The paper was obviously explained, and then an alternative treatment plan for what we would do instead of packing for these patients were developed, and a patient information leaflet about how they should care for their own wounds was designed. And that then went on for about 6 months, and I think they've looked at maybe around 40 patients. In this sort of small pilot study, they've basically found that there's a really high level of acceptability of this amongst both the patients and nurses alike. So the nurses love it. It requires far fewer wound-related nurse visits, about 85% reduction overall in visits. They've noticed an increased capacity in their clinics, and it seems that the patients are fully on board. There's less pain, less time away from work and education with this, and improved quality of life. So one thing I'd like to consider really is how do we think about wider de-implementation if we're convinced with the evidence level we've got at the moment. How do we move forward with de-implementing? How do we think about a nationwide project? What level of evidence or guidelines would be required? If we're going to develop guidelines, who should write it? Should this be a surgical-led thing? Do we need it to be a wounds nurse-led project? And I'm very open to discussion. Thank you.
Thank you, Katie, very much for that fantastic talk. I'll open the floor for questions. One at the back corner. Right at the back in the corner. Thank you.
Hi. I was just wondering what the infection rates were between the 2 groups.
As in abscess recurrence rates, or?
As in, like cellulitis, local wound infection.
So the Traditional treatment with perianal abscesses, you obviously incise and drain the abscess and then you leave it to wash out. We wouldn't traditionally give antibiotics after the operation. It's accepted that just the operation on its own is enough to clear the infection. We did look at antibiotic use and it was equal across both groups. We didn't measure ongoing cellulitis, but abscess recurrence is a really good marker of whether there's any residual infection there. So it did seem to be slightly higher in the non-packing group. Whether that represents a little bit of surgical technique, whether the hole isn't big enough, don't know.
Thank you. A question in the middle.
Thank you. Hi, Eva is my name. I work in Dublin, in Ireland, in St. James's Hospital. I just want to say, no questions, just congratulations on all that work. I'll definitely bring that back. But we are not packing for the last 5 years since we kind of implemented specialist colorectal CNS role. But it's very hard. There is a lot of resistance, especially because all those patients are usually attending emergency department and they're attended by SHOs, and they're usually not that well trained, and the usual practice is to tell nurses, oh, you need to pack this or send patient out and this needs to be packed, and then patient goes to community. There is no instruction, at least in Ireland, we don't have national strategies and stuff like that well developed yet. We're trying, but there is a lot of resistance and there is no time for training and no time for proper follow-up. And usually, yes, consultants are not seeing perianal abscesses or things like that because they're not as important. So I think that is a huge problem, but we're trying to work on that. Yeah. And do you have estimated completion date for this pilot trial?
No, this was just a very early pilot trial. The group are now looking to see whether it can be implemented widely across the whole of Greater Manchester, but it's ongoing work.
Okay. Do you have LinkedIn?
I don't, but I can give you my email address.
Perfect. Yeah. Okay, thanks.
Thank you. Any further questions? One, two over on this side, or one on the side too? Yeah.
When you're not packing, what dressings do you recommend that they're using instead? And in the trial, were they all using the same alternative to packing?
No, so it's a pragmatic trial. We didn't specify what packing dressing should be used and what non-packing dressing should be used. When we did some more in-depth studies to look as to what dressings were actually used, and it was fairly equal in that the vast majority were packed with Aquacel, ribbon, and in the non-packing group, mostly patients were given self-care and then just some simple dressings to put on themselves.
It's like just like an adhesive foam over the top or something?
Yeah, just something to catch a bit of the exudate to protect their underwear. But the vast majority in the non-packing group were actually managing the wounds themselves. And that's what they found in the pilot study, that actually if you empower patients and just say, look, get in the shower, stick a finger in once or twice a day, whack a dressing on, actually patients are able to do that. They're able to manage their own wounds.
And did it include packing with like gels, or does that not come into it? You know, like Flamagels and Flaminals and stuff. Does it look at that? No. Okay, thanks.
Well, there's some questions on the right. One, yeah.
Hi, it was more for your discussion, really. I would really welcome some guidance. I think because we have so many organisations that manage these different people, from GP surgeries, community teams and hospital teams, I think the guidelines would be really useful so that we could reach everybody.
That's really helpful. I think part of the pilot study, we are looking to develop a sort of fact sheet almost with some information, summary information about the trial, and then a what to do instead. When the pilot study's been completed, hopefully that will give people a bit of confidence that it's a reasonable thing to do.
Hi, so instead of just the perianal and the fistulas, we do a lot of like axillaries and chest walls. So would the packing be exactly the same for that?
So this study was purely perianal abscesses. As part of the pilot study, they've also looked at pilonidal sinus and cavities. I think they felt anatomically and etiologically, they're sort of relatively similar wounds. There's very little data actually out there looking at packing of superficial wounds, axillary, skin. There's a few studies from maybe 10, 15 years ago. None of them are particularly good. None of them are very big. So we don't have data about any other abscess cavities. When we've had this same question posed in sort of surgical forums, the general feeling is it's probably the same. that we can empower patients to manage their wounds themselves, dry dressing, wash it in the shower, but yeah, that the data doesn't necessarily add to that.
Any further questions from the floor? One over here, Martin.
Just more of a comment, really, about, you said the surgical team taking lead, but we discussed over there how many people are involved in this care. Maybe you should work collaboratively. There is no lead, and we all come together.
Yeah.
And then seamless transition between care and community, GP practices.
Yeah. I guess my question was, if we're going to write guidelines as to what we should be doing, should it be written by a joint group, so colorectal surgeons, nursing representation, actually to have the most power, that's probably the thing we should do.
Just wondering whether the Society of Tissue Viability can help sort of coordinate
Exactly,
that.
yeah, exactly.
Maybe we need a conversation
Yeah,
about
yeah,
how we move this
yeah,
forward.
perfect.
I'd be really keen to do
Yeah,
that.
brilliant, thank you very much.
And then just a quick one from me on a
Yeah.
research basis. So
Yeah.
obviously, visual analog scale's great, but it depends how you frame the question. So I guess one part of the question is, what specifically did you ask about pain? Was there a maximum pain score, or a kind of a diary-based, through the day? And did you consider things like nested qualitative analysis, where you could perhaps go in a little bit deeper in exploring when people were symptomatic and how they were coping?
Yeah. The pain scores we looked at, where we asked them to grade their pain before their dressing changed, so just any time before, you're just going about your normal day before the dressing has changed, during, and then within the first hour or so after the dressing change. And then we also asked them what their maximum daily pain score was, so the 4 different scores throughout the day. During the feasibility study, we did look at a couple of other measures, and we just felt that that was the one that was most likely to be adhered to. And we didn't do any more complex nested studies, I'm afraid, no.
Time for one last question, if there's one from the floor. No? Thank you very much.